So what I'm going to tell you is, everybody's telling you all this horrible stuff and the bad stuff. I don't do any of that. Okay, I spend 99% of my time with direct patient care. So in my practice, you can do whatever you want, which is really nice. If you take Medicare, you can't see people for free, but I can see people with cancer for free, and I do. So I see people with cancer for free. A lot of times I'll see their family as well, just depending on how tough their situation is. But also just so it's one less thing that they have to do. So like people with cancer, they're still getting their chemo and everything else. A lot of them do have some sort of insurance, but it's just one less thing to worry about. And I feel like I can really fill in those little gaps between when they're getting their chemo, they're nauseated, they feel lousy, and then I can come in and make sure they're doing okay and put them on an antidepressant, make sure their husband's doing okay, make sure their kids in college are staying on the ball, things like that. So that's why and I don't want it to be more and more burden. So I see people with cancer for free. I give a discount to teachers and preachers. It sounds really nice, but it started out because those were my best referrals. So those are the people who talk to the most people. And they like it a lot. If people come in wearing Spurs, I give them $5 off because I just like Cowboys. And then I can kind of just do whatever I want. If people are having a hard time, I don't have to charge them at all. If they are behind on their rent and they want to pay me next month, I can have them pay me next month. If I don't want to pay me at all, I can figure out a way they don't pay me at all. If they raise chickens and they want to bring me a bunch of eggs, I'll take a bunch of eggs. So, and it's really nice in the practice because I have worth and they have worth. And that's what I really like. I think when you have a $15 copay, if you pay $15 for something, you feel like it's worth $15. So I'm more than that. And I think my patients think I'm worth it. And I make sure that they know I'm worth it. So my patients have my cell number. They can call me 24/7. In all 15 years, I've only had 2 people abuse it, which is pretty good. 99% of the phone calls I answer, the very first thing they say is, "I'm sorry to bother you in your cell, but." So I feel like they really respect me as a doctor, but also as a mom and a human being, and it's a really nice relationship that I have. I also know all my patients. There's not a patient who comes to me and I get a call in the middle of the night, I'm like, which one are you, who, or, so that's really nice. If my patients are sick, they don't get a recording that says, if you're sick, call 911. Like, okay, we all know that. Or go to the emergency room. Like, no, that's not what it is. A lot of times I can fix it. I just got a call from a police officer. He gave me his symptoms. I'm like, go by my office. My staff is there. They know how to do a flu test. They call me. They're like, he's got flu A. I'm like, okay, I'll call him some Tamiflu. We're good. We're good. He doesn't need to go to the emergency room. That would be a colossal waste of his time. So really the thing is, like Beth and I have talked before, that the House of Medicine has many rooms, and you have to find your room. So you really want to find the place where you're going to be happiest and you can do the most good. So for me, it's one-on-one patient care. It's that interpersonal relationship. It's looking at each person individually. Like we were talking about with the Holocaust and all that, how medicine, he's like, this will never happen again. And we're like, well, it kind of already is, because they're kind of saying that these people can get colonoscopies and these can't, and these people can get mammograms, but these only get them every other year, so hope your cancer didn't start right after your last mammogram. So, because I think like the whole thing is one-on-one patient care and patient evaluation. Like I just had a lady and she said, they told me I don't need any more mammograms. Why they tell me I don't need any more mammograms? I'm like, well, because that doctor thinks you're too old and that you're going to die of something else before you die of breast cancer. She's like, well, my mom lived to 103 and she was really feisty even at the end. I'm like, well, I think you need a mammogram. So I think that's only fair, is that everybody gets individualized, because yeah, on the other side of the coin, there could be people her age that are in a nursing home facility who don't know who they are, what day of the week it is, and I see those people get mammograms all the time, and I don't think that's very fair. I think that's very confusing and mean. So I think we really need to make sure that we keep the ability to take care of each individual. And I know that that doesn't look good on paper, and there's no little step 1, step 2, step 3 thing to follow, but that's not what medicine should be. And I think a lot of the education you all get is trying to convince you that it should be that way, that there should be a gold standard and a protocol and a standard of care for everything, when a lot of times that's not how an individual works. Nobody who's writing those would think that. Nobody who's writing those standard of care guidelines would say, well, but if I feel really bad, just go ahead and don't give me anything. But overall, and when you look at cost analysis, that doesn't mean anything to the individual. Just like I tell my patients with cancer, when they say, well, they told me there's a 20% chance of survival. I'm like, well, that's true. We have to put that in there. But for each individual with cancer, it's going to be 100% or 0%. So you have to look at each person individually and which road they want to take, and give them the options. I think most people are smart enough to decide on their own. I have people who don't want MRIs, they don't want to find out, they don't want to take a statin. I'm fine with that, as long as they're well educated and understand that. I don't think everybody has to do everything that's the standard of care. So in my practice, I can do whatever I want. Nobody looks back through my books. Nobody pays me more or less if I do more or do less. I can do exactly what I learned. I don't have to spend a lot of time coding. I don't spend any time coding or knowing what the codes mean, which I think would take a lot of my time. All my time is patient care and studying medicine. I don't have to figure out what things indicated for something else. So I still have to do some prior authorizations, which I can't imagine if I took insurance how lousy that would be, because I still have to do it like twice a week, and it makes me crazy. So when they say like, the doctor, they said that you have to authorize my medicine. I'm like, I authorized it when I wrote it. And then I have to explain to them that that's just a term they use, which reminds me of that Nazi stuff too, where they call it something it's not because it sounds better. And I'm like, no, what they should call it is, we just don't want to pay for your medicine. It's not, I don't have to authorize anything. They want me to tell them why you can't have something cheaper. So, and then they still usually won't pay for it. So, and there's a lot of that I see with insurance that other doctors have to deal with, which we call the hassle factor, where if you make something hard enough, eventually people will give up. So physicians will give up or patients will give up. And same thing like the MRI that you were talking about, that takes 3 months to get an MRI. When I very first opened, I was actually seeing a lot of Canadians, strangely all the way down in Texas, who couldn't get MRIs. And we had one guy who was having headaches, bad headaches. He came down there and he said it was going to be 4 months to get an MRI of the brain. We got it the next day. He had metastatic lung cancer to the brain. What's that average survival rate for that without treatment? 3 months. So there's probably a reason it's a 4-month waiting period. Because if you're dead, you don't use very many resources. So, and that guy actually ended up living 1.5 years after that, which was really cool because he got to see his daughter graduate high school. He got to meet his grandson. It's a pretty cool 1.5 years that he wouldn't have had if he hadn't had that MRI. So, what else, Beth? I have no slides.
How did you decide to set your prices?
When I originally started, I called around and pretended like I was a patient and asked them how much it was, and then I undercut all the guys in town. Well, I mean, that seems like free market. Are you not supposed to do that? I don't know. So that's how I started, and now I've actually raised my prices because my practice is totally full. So I've raised it, but there's a point, and I just don't want to go too much higher because I have a really diverse practice. I have 2 billionaires in my practice, and then I have Mexican migrant workers, and I love having that, and I don't want to price anybody out of seeing me, because actually these really rich people, they're way more cost selective sometimes, but I love having that diversity and being able to adjust accordingly. And I have quite a few Mexican patients, and a lot of those Mexican nationals, they'll pay. They absolutely put healthcare at a paramount, and I don't want it to be too burdensome where they can't do that. The other thing I do a lot is if they have a big family, I do a BOGO, buy one, get one free. Because if you have 5 kids and they all have the flu, I'm only going to charge you for 2 of them. So I can do that, which is also really nice, especially if you have a big family. Oh, as a result, I have one family that has 10 kids, and their last kid, now they may have just run out of names, but their last kid is Juliet. And it turns out they're all pretty demure little kids, and they wear like the homemade dresses that look like Little House on the Prairie and stuff. But Jules always wears a tutu. And they call her Jules now too. They don't call her Juliet, they call her Jules, which I love. And then I have another Mexican family that just named their daughter Julieta, which is really hard to do in Spanish because the G sound, it has to be spelled with a G because otherwise it's Julieta, which is kind of ugly. But it's just really cool that people, and I guess when I started, people would say, oh, your family practice? I'm like, no, I'm internal medicine and pediatrics, okay? And now I'm like, no, I am family because I'm actually I didn't understand what family meant before. I thought, oh, it means you can take care of people from cradle to the grave. But really, my practice is like, you're part of the family and they're part of your family. And that's amazing. It's really nice when you're mentioned in the obituary or you're invited to the wedding or the kid's named after you. And it's really, and it's for real. Like, I'm for real. Just a minute ago, I got a phone call, and I think in the back they heard me. I was like, I love you too. And I was like, how many doctors get that? Like, how many doctors, patients say they love you? And that girl who I was just talking to, her mom is the one who started that at my practice. Her mom had rectal cancer, and before she left, she'd be like, love you, be like, love you too. So now it just like spread. So now that happens probably 4 or 5 times a day. Don't you think, Michael? So now like it's just a thing in my office, but it's a true thing. Like I think they really do love me, and I really do love it. So it's pretty nice like that. The other really nice thing is, again, I think my whole practice is actually just modeled around the doctor that I grew up with, who was probably behind the times in that he still made house calls. I make house calls too. And I just do exactly what he did. So I got an advertising degree, and when I first got out of school, I looked at all these contracts, and I was like, you gotta be kidding me. I have to sign a contract that says they can change my rate of pay at any time. They're gonna pay me 3 months from now, maybe, and I have to follow their rules. I'm like, I'm not gonna sign that. I'm gonna see what happens. So it worked really nice. But again, I do the same thing he did. The other thing, I love kids. I love teenagers. And I've had 17 kids live with me so far. So I started out with exchange students because it seemed a little safer. And then went to emergency foster care, and now do foster kids. So I've had 17 kids total, which has been absolutely amazing experience, and it's fun every single time. My last kid, which if I ever got slides I'll show you, was a 4-year-old. That was hard. That one was hard. I'll stick with, mostly I've had teenagers. But I also next month I'm gonna have another kid, so I'm super happy. It's one of my patients who just got diagnosed with multiple myeloma. She's gonna go from where we live to Houston to go to MD Anderson, the big cancer treatment center, and she's got to get a bone marrow transplant. So her 17-year-old's finishing high school. So this kid's gonna live with me, and I get the best part of high school. So I'm gonna get to do powder puff, prom, award ceremonies, and the mom is like, thank you so much. I'm like, are you kidding me? I get the best parts of it. So, and I feel like that's what's really neat about the way my practice is, and the way you can do your own practice is what you like and what you're good at, you can grow that. Like, I've always wanted to have more kids, and I never knew how it was going to unfold, but because of you're exposed to so many people and they know who you really are, you get to see that. You see the other families with foster kids that do well, you model yourself after them, you figure out how they do it, and you get all these secrets to life. And you get exposed to a lot of things that give you some awesome opportunities because you really are part of that family. I don't think very many people would be like, my doctor's gonna keep my 17-year-old for 6 weeks. You know, nobody would even think that. But she's like, you're kind of a logical choice, and I know you like this sort of thing. Do you mind? And I'm like, I would love that. This lady too, she had her first round of chemo. She called my office and she's like, ask Dr. Madrigal when she's gonna come spend the night at my house, blah, blah. And I was like, what is she talking about? I was like, I don't know. So I told my staff, I'm like, call her back and see what on earth. And they're like, she says that you said you would do anything and help her. Kind of sounds like something you would say. I'm like, crap. So I thought this is gonna be really uncomfortable. So her husband was out of town. He absolutely couldn't come in, and she's scared. She's like, I'm just really scared on how I'm gonna do after my first chemo that night. And I have a 17-year-old, goofball and me. She lives like a block away from my office. I live right there. I'll make you dinner and breakfast. What do you say? I'm like, I have a slumber party. And we ended up having a great time. But again, I'm like, this is a first. So, the other day I did a house call and the lady has pancreatic cancer. So most my house calls are people who have cancer and most of them aren't slumber parties. But I went over there and she's like, they told me I could eat today. It's the first time I can eat since my Whipple, but I don't know how much. And I was like, I don't know, what are you having? She's like, ham. I was like, let me go cut it up. Like, how many doctors are cutting up people's ham in the kitchen? But that's really neat to be part of that family and to get to do that and be a part of it. The other thing is I have the time and I'm not overly burdened with all these codes and all this other stuff. So I also started a nonprofit. So my crazy thing I do, because all that other stuff is sane, is flying trapeze. So I started flying trapeze 5 years ago, and two of the guys that I worked with, who worked with me there, were both foster kids. So that's kind of when I started doing all the foster stuff. So we started an organization called Circus of Hope, where we get kids who are in group home settings. One's called the Helping Hands Home. It's kids who are severely abused, neglected, or abandoned, and they're too damaged to go into foster homes, so they're in a group home setting. And we take them out to the flying trapeze rig, put them on a 30-foot platform, drop them off, and teach them how to trust, how to do something amazing, how to be really cool people, how to be positive towards one another, how to get these little bonding situations going. And that has been a blast too. But I don't think I could do that if I had another job. I don't think I could do it if I had a different kind of job. I think I'd just be too mentally fatigued sometimes, because sometimes when you come home from work and you've been working, doing numbers and codes and all that kind of stuff, you don't feel like doing other stuff. And that's my job gets me pretty hyped up, obviously, but in a good way. So my job affords me a lot of really neat opportunities like that. And again, I think this is pretty much just how the old-fashioned doctors used to do it. And that's why they did it. That's why people did house calls, because they actually cared about the other person, and it's really rewarding to go take care of somebody and really help them. Having them come into the office when it's flu season and they're on chemo and they don't feel good, I don't think that helps them near as much as me just zipping by on my way home.
How many patients do you see in a day?
A lot. 20. So I think that's a lot. So, and I can spend as much time as I want with them. The other day we were way behind. And sometimes I get way behind, but nobody complained. I tell them I'm really, really sorry. But they all said no, because now it's my time. And I'll take as much time as I need. And they do, and that's fine. And I may not get lunch that day, and that's okay too. So make Michael go get it. Send the student out. So, but, and that's another thing that I really like. I see some of my friends who work at big clinics, and they just say it's just so much pressure to see more, code more. And I don't have that at all. And if I want to take off on a Thursday and come to Ohio, I can do that. So, and nobody really suffers for that per se. So, I'm trying to think what else is in my head.
I think. Go ahead.
This is fantastic. Great talk, positive energy.
Even though I have no slides and don't know where I'm going.
Where do you think you can push that boundary of what you can do with your practice? So, to what extent, people are doing sutures and then simple casts. You deliver something. How far can we go with a model like this? What's the complexity of it?
I think you can go pretty far, and it depends. Like my friend Keith Smith in Oklahoma City, he has a whole surgical center that way. Because you would say there's no way you could do this and be a surgeon, but he has lots of surgeons that work for him and do it that way. I have another good friend who's an orthopedic surgeon, and he doesn't take insurance, or he takes very few actually. So I think you could do whatever you want. I think you can make it work. You can also, like the other thing I do is if I like it, I don't charge very much. If I don't like it, I charge more. So like I hate abscesses so bad, okay? That's why I didn't go into family. I did Med-Peds, so you don't have to do surgery. But if somebody comes in with one, I'm like, that's gonna be $350. And they're like, okay, I'm like, kinda like this. Like it's hard not to like it when you know it's gonna pay for your daughter's gymnastics lessons, So, but back to your question, I think really you could do it in almost any, you probably can't do it as an anesthesiologist unless you work for Keith Smith or you start your own like he did. But otherwise, I know a lot of derm, I know a lot of different doctors and a lot of specialties who do it now. And some people do the other models where you do like a gym membership and you pay for a membership and they come in. I tried that for a short period of time. Actually, I tried it with a few local businesses. Like there's a auto repair place and they wanted, they paid me like $100 a month for each of their employees. I hated it because like 3 people came in all the time. The other 7 never came in. Then later, after he quit doing it, one of those 7 came back, and I was like, well, you paid for it, and you never used it. I just can't do that. To me, it's communism, pay for others, and I don't know, I just don't like it. I know a lot of people do. Again, I don't like it. I like if you're difficult and take a lot of time, you know it, so you should pay more for it. If you're healthy and don't have any risk, then don't pay for it. So, but that's just me. I know a lot of doctors love the model. Plus, I like to have all kinds. Like I like to have the whole gamut of society in my office, and I think that lends itself more to the wealthier people who can afford it. But
so patients that come in your office who do have insurance through employers or whoever, do they have the opportunity to bill insurance? Will you code for them on that circumstance?
Yes.
So
most of my patients do have insurance actually. So yeah, we'll give them, if they want, we'll give them before. Most of them don't want it. And sometimes at the end of the year, they'll be like, gosh, I saw you more than I thought. Can you give me one that does the whole year, the 6 times I came to see you? But rarely do they want it. They're like $100, 3 times a year, So, and Medicare they cannot though. So if they have Medicare, they cannot get reimbursed, so they have to know that. So,
How do you work with the hospital?
Right, I did.
Services, your lab and x-ray and everything.
Oh, how do I order ancillary stuff?
Yeah, how do you work with it? Like, do you get discounts for your patients or?
Yes, that's a good question. So for my lab, I actually just work with, I have 2 competing lab companies. So I think you're starting to know kind of my philosophy. But so I find out whichever one's the cheapest, and I can get, and so that's the other way I actually make quite a bit of money off of patients that don't have insurance that go to other doctors. So we have a big conglomerate practice in our little town that sees probably 70% of all the patients. Any of those people don't have insurance, those doctors will secretly pass them to me to get lab, because I can do a CBC, a complete metabolic panel, a lipid panel, and a thyroid, and include the draw fee for $98. It costs $1,000 at their lab. So that it's just sometimes the patients will come in and they'll have some weird lab like celiacs or something like that, and I'll be like, I'm so sorry, it's going to be like $200, and they're like, I got this exact same lab 2 weeks ago and it cost me $4,000. I'm like, you're welcome. So, but that's really nice, and even with that lower price, I still make money off that. I still make a good amount of money off of that, which also gives me this really nice buffer if somebody gets raped and I want to do a gonorrhea and chlamydia, I don't have to charge them. I get this really nice buffer that I can use if I need to. So.
Are your prices, I know they're transparent, are they published?
No, you can. I don't. And that's what we were just talking about. I don't, because right now I don't need more patients. But that's the only reason I don't right now.
Do you think that if you publish them in your market, This can be right here in Texas. What area are you in?
Around Austin.
Austin. Okay, so other providers in Austin, do you think you could actually, just from on a principal level, drive prices down at your colleagues' offices if you?
I don't think so, because so many of them work for big organizations. So they don't even know. A lot of the ones who send me the cash people are the ones who do know how expensive it is. But a lot of them, they don't know and they don't care.
Are there other DPC providers in the area?
Yes, there are.
Is there competition? Do you sense competition?
No, we have very different patient populations. So, and they do the membership, concierge stuff. It would make me crazy, but so.
Cool.
What else? Go.
When you're co-managing like an oncology patient, what's your relationship like with the primary team, if any? Do they appreciate you like taking care of some of this stuff? Do they resent having multiple cooks in the kitchen?
I think I think we have 15 doctors in our town, and I think I have 11 of them as patients. So I think they kind of get me. So, and I think they really appreciate that. And then I tell them too, I'm like, hey, if you have somebody who has cancer, I'm not taking new patients, but if you have somebody with cancer who needs me, send them. It's free. I got it.
And what about I'm curious, the hospital question.
Oh, hospital. So I did used to do hospital. I don't anymore because we have hospitalists there. So I do have courtesy privileges there. So I do make, I call them howdy rounds. So I do go to the hospital if my patient's in the hospital and say hi and check their chart and make sure there's nothing really weird going on. But I don't do hospital work at this point. So.
Do you feel you're competing with urgent care in the area?
Yes.
And do they feel that about your clinic?
I don't think so, because they're not very good, and I think they'd be better if they thought they were competing. So, as a matter of fact, our urgent care said, our urgent care can't give IV fluids. We do IV fluids, so they ask if they can send them to us. So, I don't feel like we're competing. We should be. I would love it if they would compete.
If you have uninsured patients that are going to require specialty care, like an endocrinologist or I don't know, maybe an enterologist, whatever the case would be, how do you manage that with those patients?
Well, the same way any doctor does who has an uninsured patient, right? So, but I do know which doctors will take uninsured. Like rheum is a nightmare. Rheumatology, I have to do way more rheumatology than I'd like to, because none of our rheumatologists in the whole Austin area will see a patient without insurance, which I think that's a little immoral, because there's certain religions that don't allow you to have insurance. There's certain ethical backgrounds and beliefs that don't allow for it. So I don't know how they can not take American cash, but some of them don't. But otherwise, I know which ones take patients that don't have insurance. I know which ones give a discount to cash paying. And a lot of times, I don't have to do it so much anymore, but I used to tell them, like, okay, wait, you're charging $500 for a cash payer to come see you for endocrinology. How much is Blue Cross Blue Shield paying you? And they're like, I don't know, $50. I'm like, charge my patients $150. So I don't know. Sometimes if you explain, really, you'll still make a ton. But.
What was your transition like from regular practice into direct primary care? It's kind of like a novel idea still. How did you cross those barriers?
Well, I went straight in. Actually, I went from residency. I worked in the ER for a little while, which really built up. Again, in a small town, they're like, that little girl doctor, I'm gonna go see her. So that actually already had built up some clientele, and then I just started straight away. The only thing I had been exposed to was residency, medical school, which is just the opposite, and it was just amazing because it was just so much easier. And again, I can just use all the skills I learned every day. I don't have to spend a lot of time looking stuff up, and so my learning curve coming out of residency was not very steep because it was all just medical stuff, which you guys are extremely well trained in. So, and even the financial stuff, I just decided what's the average amount a primary care doctor in my area should make, how many patients a day do I want to see, how many days a week do I want to do, divide it out. So, and honestly, I make way more than most doctors do who are in my field, and I'm sure I make way more than people in my little town do, way more. I try not to let them know how much I don't want them to know, honestly, but I do really well because it's just money in, money out. It's how much it's your overhead, and what's left in the cash drawer at the end of the day is how much you take home. And I think that we're worth it. I think we work really, really hard. You know, you're gonna miss your kids' first steps. You're not gonna see the preschool play. I mean, we make a lot of sacrifices for other people, and I think we should be rewarded for that. I don't think I live extravagantly, but I think I get paid what I'm worth and maybe a little bit more, which allows me to give back a lot more. So, and that's the other thing I think they teach you in med school and with all this stuff. You're not supposed to look at the numbers. You're not supposed to care how much you make. You're supposed to put in all this time and money in medical school and residency, and then you're supposed to, how dare you think about money, but it's kind of nice to have it. It's nice to have a nice car that gets you where you want to go. It's nice to be able to send your kids to a good college wherever they want to go, and it's nice to be able to take in foster kids and not have to worry about it. So.
You see any legal pushback from what you do?
Not now. In the beginning I did. In the beginning I was kind of nervous because they really didn't want me to exist. But now there's so many more doctors. Like when I started in Texas, there were like 15 doctors that had opted out of Medicare. Now the list is so long, it's ridiculous. So there's so many more now that I think there is some safety in numbers. So I think if they went to a single party, I've spoken before Congress 3 different times. I've given 3 congressional briefings, and they want me to exist. They want to come to a doctor like me. They don't want the doctor that tells them they can't get this test or this procedure or they can't get this medicine. So I think, again, everything's really comes down to the individual. I think they want us to still exist.
Mm-hmm. So, direct primary care is something I'm really interested in, especially like listening to some other videos and hearing you. It just like excites me even more because the only reason why I want to do medicine is because I want to be patients.
Right.
I don't care about anything else that it feels like it's what I want to do. But the only concern I had is the pay. You said you do really well. Is that typical? Do you think of this model that physicians can make just the average or better?
I think you should make better. Yeah, because your overhead should be way less. I have way less staff. Right? I can search around for really good prices on stuff. I can raise my prices. Like, if you want a testosterone test, I charge way more for that because I don't have to deal with your stuff. So, but you know what I mean? You can do whatever. Again, I don't like it that much. I mean, I had to look at your penis. I don't want to. So, but no, I think you can do extremely well. And sometimes people say, well, the only reason it works is because you're in a small town. It would work better in a bigger town. I'd have way more people to pick from. And the neat thing about it is it will evolve to what you like. You'll get the patients you like. Unfortunately, I like poor people. No, but I mean, I actually like people all across the gamut. But if one of my friends does this real foo-foo, hoity-toity thing where they only have like 200 patients and they give them all little gifts on the holidays, like that's cool if that's what you're into. That's not me. I'm not a crafter.
What about starting out? Did you take out big loans for any equipment or anything like that? Or is it not?
No, I took out very little. And that's the other thing. I come from very humble means, so I did it just like I did everything else. So I just rented a slip in another guy's office. I borrowed some of his equipment. I stole some tongue depressors from the ER. I actually had to steal some gowns from the ER because I didn't have any gowns. So I took them. After I had like a week of patients, one was a seamstress. She copied it, made me gowns, and then I got called when I was taking the gowns back to the ER. They're like, what are you doing? I'm like, nothing. But I mean, I just started it really basic. I had one otoscope, and just carried it from room to room in my pocket. So I just started I didn't want to take out loans. I had 2 little kids at the time, so I just wanted to be as easy as possible. Had 1 exam room, then I got 2, then I got 3, then I moved to a different building, and it just slowly, I don't have an interior decorator, I don't have a big old fish tank, I don't have TVs, I want them to read when they're in my waiting room, So it's still kind of basic, but again, I think the patients appreciate that. My patients appreciate it because that's who I am. So.
I think your question, Tony, though, about the DPC, it's a small business.
Yeah.
And there are people who know how to run a small business and can make it work. And there's a fair number of docs who try and start a DPC practice, whether it's a membership or a fee-for-service, that don't make it. And maybe they chose the wrong area. Maybe their prices were wrong. Too much competition from, or just nobody understood what it was. So you're taking a risk. So you definitely have to do your research, and you have to understand that you are a small business owner.
And a lot of it's personality driven. I don't know if you can tell this, but I have a very big personality. But some of it, and I have seen other people who are very shy and demure who don't do particularly well in this model. You have to go get them. And again, I'm good at that. If I'm in the grocery store and somebody sneezes, I'm like, I know a good doctor. I do it almost every time. In the beginning I really did. And that's why I have all those other doctors. All the girls at the bank I bank at, they're all my patients. Of course they are. I'm like, what's that goiter? Is that a goiter? They're like, oh my God, it was a goiter. She'd been trying to get pregnant for 1.5 years. I found out I couldn't help it because she had a goiter, fixed her thyroid, boom, baby. So they are all coming to me, because I'm always a doctor. I'm always a mom, I'm always a doctor. Those are two things I always am. So if you're like that all the time, you'll get the patients. My kids have brought me the most patients, and having kids and being involved, going to baseball games, going to the plays, talking to teachers, that church, getting out there, and not being afraid to say, I'm a doctor, or, you don't look good. Sorry, you look like hammered snot today. What's up? Whatever. Like, that's what brings me patients. And I think it is a little, I guess, you do have to work harder over here. Like, do you want it to be over here, or you want to be on paperwork? This is me. So that was easy. But yeah, it's not going to be for everybody, because it is so, they're coming to you to see you. Not because a card tells them to. So, because they like you and they trust you and respect you, all those things. But you do have to sell it. So,
2 quick questions. One, so a lot of direct primary care docs are shy of taking on chronic pain patients. Is it concerns you can need to use a narcotic, then all of a sudden you're in the scopes of your state medical association. So that's question A, how do you manage those patients if you do? Question B, in terms of cost transparency, since you don't advertise your costs online, how do the patients just call and find out? How does that transparency get communicated to them, especially if they're going to require blood work at the end of the appointment they don't know they're going to need? So how do you, I guess, keep it as transparent as possible, and how do you manage chronic pain?
So I don't do chronic pain. I do have a few patients who have chronic pain that I treat, but I don't do chronic pain for a lot of reasons. But that is a little scary, because a lot of people who abuse the system and write too many pain medications take cash. Okay, so I don't want to be anywhere associated with those people. I stick to the guidelines for pain medicine. I give them 12 at a time. I'm not ever going to do 180. I'm just not. A lot of people do though, but that's my deal. I do a lot of addictive medicine. My whole family has alcohol problems. I don't want to be part of the problem. If you want to get off stuff, I'm your answer. If you want to keep using, you're not going to like me. So I don't do that. What was the second part of the question?
Cost transparency?
Oh, when they call, we tell them. So we tell them it's going to be between $75 and $150. If you need lab, when was the last time you had lab? 4 years ago, you're probably going to need lab. It's probably going to be about $100 more. So, and we keep it arranged, because if patients are difficult, I charge more. Well,
Can you explain that?
Well, some patients are difficult.
You like personality, or like they have an extra CBC and like?
Both. Well, if you have like congestive heart failure and diabetes, and you're depressed, and you're not sleeping good, and you want to talk about your mom, that's going to cost more.
So you don't give the price till the end?
Correct. But they have an idea. There's a range. So, because I want to get paid for working harder. So.
What is your approach to documentation? I'm very curious.
I was in the computer generation, so I like computers. I do this program called Amazing Charts that only costs like $2,000 total. It may have gone up now, but it's really cheap. And I just do it and I store it all there. So I don't store it It doesn't go anywhere else. It just stays there, so all the patient records stay there. And I do have quite a few patients who come to me just for patient privacy reasons. And I have some people who come get an exam from me before they're going to go get their exam for their special license or whatever, just to make sure that they're not going to fail it and not know it. So,
So for comparison's sake to an internist you'd see anywhere else or a Med-Peds you'd see anywhere else, what is your average face time with every patient that you see?
Probably 20 minutes or so. A new patient probably takes me a good hour, depending on how complicated they are. And that's why I have that lunch, and if I don't get lunch, I don't care. That's my bleed over time. And if I stay late, I don't care. And I try to schedule them as such: easy stuff, hard, harder, easy, hard. And it kind of works out. I have a really good office manager who is like magic on stuff like that. But probably 20 minutes. If you have the strep, you can be out in 5, and then I, can spend more time. And sometimes I just talk too much.
Are you predominantly paper records?
I do both. So I do it on Amazing Church, which is computer. And I like Amazing Church because I do my own templates and I just cut and paste them in there. So I cut and paste them and change them accordingly, and it's really quick for me. It's faster than writing. But I do backup paper copy because everything's just on my office, and if something weird happened, I still want your records. So I know it's redundant, but it is what it is. So
what happens when it rains?
What do you mean, if the electricity goes out?
But you told me, was it?
How I save patient. So if it's rainy, we save our acute visits for the Mexican workers because they won't come in, they won't miss work. So on rainy days, we schedule those last few visits for people who work construction. So, we got this system down. So, and we do afternoon appointments for teachers also, which most of them want to miss work anyway. They're like, I have sick days. And then we do, and I'll even be open on a holiday a lot of times, so I can see my college kids or my other patients a lot of my patients are very hardworking, so I'll work a holiday just so I can see my college kids and my people who hate taking off. So.
How many days a week do you have clinic?
4, which is also awesome. So I took off Wednesday, which was traditionally a doctor's day off. Now I'm getting phone calls and stuff, but I don't care. I can also be on the trapeze.
Do you make do you go to visit patients at their homes like on the weekends or stuff?
No, usually I do it at lunch or on my way home from work. So almost always on my way home from work. I used to tell them they had to feed me, but then it turned out a lot of them had cancer, and that didn't seem right. So. Although last time I got some banging banana pudding, so that was totally worth it.
What are your hours you post? Your posted hours?
8:30 to 5, but really I usually don't get there till 9-ish, and I usually work till 6. So I usually work 40 hours, but without that Wednesday. So that makes it work. Because I'd rather work really, really hard when I work and then have that middle day off. But that's just me. That's what works. I can do anything for 2 days straight. After that, it's questionable. And that's how it used to be. Doctors took off Wednesday to play golf. So that happened for a reason. It wasn't because they were slackers, it's because they needed a day off. So I kind of respect that. So. Okay, yeah.
To encourage your patients, do you feel like most of it is urgent care type walk-in, or do you think most of your appointments are more scheduled in advance?
50-50. Yeah, I love urgent care. Obviously, I worked in the ER, so I love urgent care, so I think that's why I have more urgent care. But I way prefer urgent care if I could, but I've got to do diabetes because I'm an internist.
I guess get that advertising up for the urgent care type visits.
Just word of mouth. So, and again, having appointments available, that's the other thing. A lot of my patients who have insurance will go to other physicians for certain things, but then if they can't get in, they can come to see me. And I keep places like that available too. And even since I'm not taking new patients, I will take them if it's an emergency or a semi-emergency, things like that. So, or they're somebody's cousin or whatever. So, well, I had awesome pictures. I'll tell you my favorite one. I just have a lady who did a mural on my wall, and it says, "Trust your journey." And it was actually a tribute to one of my other patients, the one who actually got me started in trapeze. So this patient is in front of it because she painted it. Well, she now has metastatic cancer of unknown etiology. We cannot find the primary. And she came to me and said, "I don't want to do it. I'm not going to do chemo. I feel horrible. Just be there for me on this journey." So I have her in front of her mural, and then there's a picture of her hugging me, and when she's hugging me, you can tell she's like, "I just totally trust this woman," which is really nice. So, all right, thanks for listening to me. Sorry about the presentation.